Hello everyone. Today we are going to deal with a very important topic for practical as well as theory point of view, that is nephrotic syndrome. Uh, you are definitely going to get a case of nephrotic syndrome in your pediatric practical exams, DNB exams. Most probably they will keep nephrotic as a short case for the ward round. But in some centers where the number of cases are not that much available, they can even keep nephrotic in long case. So we will deal with nephrotic today. Quick review without wasting much time, as you guys don't have much time for electro practicals now, and it's not possible for you to read nephrotic from any big textbook. So I am trying to cover most of the important part from standard textbooks. Okay. So let's move on to nephrotic. It is a clinical manifestation of glomerular disease associated with heavy nephrotic range proteinuria. So what is nephrotic range proteinuria? It's defined as proteinuria of more than 3.5 gram per 24 hour, or specifically more than 1 gram per meter square per day, or a urine protein creatinine ratio of more than 2. This is very important. More than 2 is termed as nephrotic range proteinuria. Okay. The clinical triad of nephrotic syndrome. There are various features in nephrotic syndrome patient, but standard textbook gives a clinical triad of nephrotic, which results from large urinary losses of protein. So the triad comprises of hypoalbuminemia, that is decreased albumin concentration in blood less than 2.5 gram per deciliter. Next is edema due to fall in plasma oncotic pressure. Edema you can see in periorbital puffiness, pedal edema or generalized edema in later stages. And the third one is hyperlipidemia, that is cholesterol level of more than 200 milligram per dl. So this can be a viva question, that what is the triad of nephrotic syndrome, clinical triad. Some epidemiological point, it affects 1 to 3 per 1 lakh children of less than 16 years of age. Now this is a good question. Most common cause of death in untreated nephrotic syndrome is infection. It's not thromboembolism or any cardiovascular cause. The most common cause of death in untreated nephrotic is infection. 80% of children with nephrotic syndrome responds to corticosteroid therapy. Now, etiology of nephrotic syndrome, we are not going to deal with this in detail, as this theoretical aspect, and you can read from any textbook or from these slides. But just keep in mind, in primary nephrotic or primary idiopathic nephrotic syndrome, where no other organic illness or no other systemic disease or any other cause is there, so that is termed as primary idiopathic nephrotic. And the most common cause in pediatric population of primary nephrotic syndrome is minimal change disease. So every one of you know this well. There are now different other types, but most common is minimal change disease. Now there are various genetic disorders associated with proteinuria or nephrotic syndrome. We can go through them. Proteinuria with or without nephrotic can be seen in Neil-Patella and Alport syndrome. There are various multisystem syndromes involved. Next is metabolic disorders where proteinuria is seen. And now we comes to nephrotic syndrome, secondary causes of nephrotic syndrome, where any other etiology will lead to nephrotic. So infection is a very common scenario where infection precipitates to nephrotic, and in Indian population tuberculosis is the very important cause of nephrotic. So in each and every nephrotic patient, if you are suspecting nephrotic or is going to start the treatment, then tuberculosis has to be ruled out by clinical and other investigations. Next is drugs. These are the different types of drugs, few examples which can lead to nephrotic. Immunological or allergic disorders, and any malignant disease like lymphoma, leukemia or solid tumors, thymoma may lead to nephrotic. And morbid obesity is also a cause of nephrotic syndrome. Now pathogenesis of nephrotic syndrome, this we will see in a bit detail. What are the role of podocytes? The role of podocyte is very important in pathogenesis of nephrotic syndrome. The underlying abnormality in nephrotic is an increased permeability. The permeability of the glomerular capillary wall increases in nephrotic, which leads to massive proteinuria and hypoalbuminemia. Like this is the glomerular wall, and if the permeability increases, then it leads to loss of protein in urine, which leads to massive proteinuria and hypoalbuminemia. Now what are podocytes? These are structural support of capillary loop, major component of the glomerular filtration barrier to proteins, involved in synthesis and repair of glomerular basement membrane. So podocytes are the determining factors of loss of protein or albumin in urine, and This is the center of pathogenesis of nephrotic. So important component proteins of the slit diaphragm. These includes nephrin, podosine, CD2AP and alpha-actin N4. So these proteins usually play a pivotal role in development of nephrotic. A podocyte injury or genetic mutation of genes producing podocyte proteins may cause nephrotic range proteinuria. So any injury to podocytes will lead to nephrotic range proteinuria. Common mutations NPHS1, WT1, NPHS2 are the most common mutations seen. Now genetic mutations of podocyte genes decreases by age, like it is around 66% in the congenital nephrotic cases and which decreases to around 15% in school age patients or adolescents. So as age increases, the probability of genetic mutations of podocyte gene decreases. So what happens in nephrotic syndrome with podocytes? There is decreased number of functional podocytes, altered slit diaphragm integrity, and the end result, the important part is this, the end result is increased protein leakiness across the glomerular capillary wall into the urinary spaces. So podocyte damage is the central part in pathogenesis of nephrotic syndrome. Now, is there any role of immune system in pathogenesis? Yeah, various theories suggest that there is role of immune system, like minimal change nephrotic syndrome may occur after viral infections, any allergen, Hodgkin's lymphoma, T-cell lymphoma. So this proves that this suggests that there might be some role of immune system in nephrotic. Also, immunosuppression drugs like corticosteroids and cyclosporine. Corticosteroids is the drug of choice in nephrotic syndrome, and which provides additional evidence that immune system contributes to the overall pathogenesis of nephrotic syndrome. So if any drug, if any immune suppression drug is curing that disease, that means definitely there should be some immunological component leading to pathogenesis of this disease. Now, this is a good and very important flow chart which you should remember, which will clear concepts about the why the symptoms, what are the clinical signs which developed and how these signs are developed in nephrotic. So there is supposed to be an inherent T cell dysfunction which leads to release of cytokine like substances, which leads to glomerular basement membrane changes, which finally leads to proteinuria. Now proteinuria is the central part of nephrotic. What happens with proteinuria? There is loss of albumin, there is loss of IgG, immunoglobulin G, there is loss of antithrombin 3 and loss of lipoprotein lipase. So loss of albumin leads to decreased plasma oncotic pressure obviously, and which leads to the most cardinal manifestation of nephrotic syndrome, that is edema and hypovolemia. Now loss of IgG leads to susceptibility to infection. Now these are important questions which can be asked in Viva. Examiner may ask you that what is the cause of susceptibility to infections in nephrotic cases. You should not stand blank there. You should know that it occurs due to, now if you will reply it's due to hypoalbuminemia, it's totally illogical answer. Loss of immunoglobulin G specifically leads to susceptibility to infections. Likewise, loss of antithrombin 3 leads to hypercoagulability, and loss of lipoprotein lipase leads to hyperlipidemia in nephrotic cases. So this is a good and important chart. You should remember this and go through it once. Next, the clinical consequences of nephrotic syndrome. Edema is the most common presenting symptom of nephrotic syndrome. There's nothing new for you. You have seen all the cases of nephrotic, none of them presents without edema. Two opposing theories which describes the pathogenesis or development causation of edema in nephrotic. These are underfill hypothesis and the overfill hypothesis. Now, what is underfill hypothesis? Underfill means something which is less filled. Okay, and overfill means something which is totally filled and it's coming out of that container. So underfill hypothesis means, what does this hypothesis states? That nephrotic range proteinuria leads to fall in plasma protein level, corresponding decrease in intravascular oncotic pressure leads to leakage of plasma water into the interstitium and generating edema. So what does this leads to? This results in reduced intravascular volume, increased secretion of vasopressin and ANF, which along with aldosterone results in increased sodium and water retention by tubules. So sodium and water retention therefore occurs as a consequences of intravascular volume depletion. Now what underfill hypothesis is suggesting, that the final consequence of edema is sodium and water retention. Sodium and water retention happens, edema occurs. But why sodium and water retention is taking place? Because of intravascular volume depletion. So depletion is there, means there is something which is underfilling. Intravascular volume is underfilled, intravascular spaces are underfilled. So this leads to increase in release of vasopressin, ANF and aldosterone, which leads to increased sodium and water retention, and which finally leads to edema. So this is underfill hypothesis. Now next, what does they say? That this hypothesis does not fit into the clinical picture of some patients with edema who have clinical signs of intravascular volume overload. As in the previous slide, we have seen that intravascular volume depletion leads to sodium and water retention due to ANF and aldosterone. But if a patient is having features of intravascular volume overload, then how you are going to explain underfill hypothesis? So this opposes the concept of underfill hypothesis. So if the patient is having intravascular volume overload, those patients are to be treated with albumin plus diuretics together, not albumin alone. Okay. So albumin will increase the oncotic pressure and diuretics will decrease the excessive intravascular volume. So next comes the overfill hypothesis, the opposite hypothesis. It says nephrotic syndrome is associated with primary sodium retention. Now what was happening in underfill? Sodium retention was occurring because of intravascular volume depletion, and overfill hypothesis says that there is primary sodium retention in nephrotic with subsequent volume expansion. Expansion means overfilling and leakage of excess fluid into the interstitium. So the intravascular volume is expanding and it's leaking into the interstitial spaces, which leads to edema. So epithelial sodium channel in the distal tubule plays a key role in sodium resorption in nephrotic syndrome. They are saying that there is primary sodium retention. Which cell is helping? Epithelial sodium channels in the distal tubule are helping in reabsorption of sodium in nephrotic syndrome. Now, what is the weakness? There was also some weaknesses of underfill hypothesis, overfill hypothesis weaknesses. There are numerous nephrotic patients present with picture of intravascular volume depletion, that is low BP, tachycardia, elevated hemoconcentration. So how overfill hypothesis is being explained in those patients? So this opposes that theory. And next, for amiloride, which is an epithelial sodium channel blocker, used alone is not sufficient to reduce adequate or induce adequate diuresis. Like here, they are saying that epithelial sodium channel plays a pivotal role or the major role in overfill hypothesis and generation of edema. But if we give that blocker of the sodium channels amiloride, that itself, only that drug is not sufficient to induce adequate diuresis. So both of these theories have their pros and cons, opposing and supporting evidences. So none of them has been proved to be 100% correct. The goal of therapy should be to reduce gradual reduction of edema with judicious use of diuretics, sodium restriction, and cautious use of intravenous albumin infusion if indicated. So this you guys have already seen in clinical practice that advance we don't use diuretics in nephrotic patients with edema, only if there is severe distress or massive effusion or massive ascites leading to respiratory distress, or the edema is refractory to corticosteroid therapy, then only we will start with diuretics. Sodium restriction is advised, but strict restriction, they should not use extra salted foods like pickle or chips or something like that, but normal food salt should be there, because you can't restrict 100% sodium from a child. So, and cautious use of intravenous albumin infusion if the edema is very much refractory and there is severe hypoalbuminemia persisting even after steroid therapy. Next is hyperlipidemia, increase in cholesterol, triglycerides, low density lipoproteins, VLDL. The HDL level remains unchanged or is low. There is result in increased synthesis and decreased catabolism. So synthesis is increased and catabolism is decreased. So overall there is increased level of lipids in nephrotic cases. Increased susceptibility to infection. We have seen that the nephrotic cases present with cellulitis, spontaneous bacterial peritonitis, and bacteremia. Many factors play a role, like hypoglobulinemia. As you have seen, IgG levels are decreased. Also the complement levels C3 and C4 are lost in urine, and alternate pathways factors B and factor D are also lost in urine. So overall all of these leads to impaired opsonization of microorganisms. So there is always an increased risk of encapsulated bacterial infection, particularly pneumococcal or meningococcal. Spontaneous bacterial peritonitis may present with fever, abdominal pain, and peritoneal signs. Now these points can be asked in viva during case presentation or even during OSCE. Any clinical scenario can be made for spontaneous bacterial peritonitis, like a case can be given that a patient presents with periorbital puffiness early morning and all the features suggestive of nephrotic, and they will ask you that the patient is having fever, abdominal pain, and peritoneal signs, so massive ascites. So what is your probable diagnosis? So diagnosis will be spontaneous bacterial peritonitis. Next, they may ask that what is the most frequent cause of this clinical condition. So you have to write pneumococcus infection, and the peritoneal leukocyte count or ascitic fluid leukocyte count more than 250 cells per microliter are highly suggestive of spontaneous bacterial peritonitis. So these are viva as well as OSCE questions. It goes either way. Next clinical feature is hypercoagulability. Nephrotic syndrome is hypercoagulable state. Okay, and why hypercoagulable state is there? Because of vascular stresses from hemoconcentration or intravascular volume depletion, increased platelet and aggregability, and change in coagulation factors level, as we have seen in that flow chart, that antithrombin 3 level decreases. So increase in hepatic production of fibrinogen. Now fibrinogen level is increased, and urinary losses of antithrombotic factors like antithrombin 3 is decreased and protein S is decreased. So overall hypercoagulability is seen in nephrotic cases. Now comes the most common type of nephrotic syndrome in pediatric population, which is the idiopathic or primary nephrotic syndrome. 90% of nephrotic syndrome in children is idiopathic, associated with primary glomerular disease without an identifiable causative disease or drug. There are various histological types, but most common is minimal change disease in pediatric population. Now, pathology in minimal change disease, what happens? Total 85% of cases are nephrotic in children. Glomeruli appear normal or a minimal increase in mesangial cell matrix. Immunofluorescence microscopy is negative. There are no changes or no abnormalities seen in mesangial matrix. Electron microscopy may show effacement of the epithelial cell food processes, and more than 95% of the patient of minimal changes responds to corticosteroid therapy. Now, this is an important point. 95% of the prognosis or the treatment of nephrotic syndrome in pediatric population is good. 95% have minimal change disease, and they respond. 85% have minimal change disease, and they respond well to corticosteroid therapy. If you are not responding to corticosteroid therapy, that means either they are steroid resistant variety, or there might be any other histopathology of nephrotic syndrome in these group of children. We will not go through these in details. You may just go through the slides for practical purpose, because mostly minimal changes is seen in pediatric population, so examiner might not ask these details about other histopathological varieties. And focal segmental glomerulosclerosis is another thing. You can remember these as FSGS may be seen secondary to HIV infection, vesico-urethral reflex, or IV use of drug abuse. And only 20% of FSGS patient responds to prednisolone. Around 95% responds to steroids in minimal change disease, while only 20% responds to steroids in FSGS variety. Now, the clinical manifestation of minimal change disease, male is to female, 2:1. These are just epidemiological things. Most commonly appears between ages of 2 and 6 years. It can be asked that what is the most common age group for minimal changes is 2 to 6 years. FSGS is most common in adults. The initial episode of idiopathic and nephrotic and subsequent relapses may follow minor infections or reactions to insect bites or bee stings. So mostly we see that any patient with relapse of nephrotic usually have preceding infection of either cold, fever, or any abdominal infection, which precipitates the relapse of nephrotic syndrome, or even the first episode. Okay. So next is children presents minimal changes with mild edema, initially noted around the eyes and lower extremities. Now this is a viva question. The edema in nephrotic is pitting. It's not pitting, it's pitting edema. With time, edema becomes generalized. Ascites, pleural effusion, and genital edema may be seen. Anorexia, irritability, abdominal pain, and diarrhea are common. Now, important feature of minimal change disease is absence of hypertension and gross hematuria. So these are the features which will differentiate nephrotic from nephrotic. There is usually in minimal change disease there is no hypertension and there is no gross hematuria. Even in some later stages, patient can develop hypertension, but the initial stages of idiopathic nephrotic syndrome usually there is absence of hypertension and there is no gross hematuria. So the differential diagnosis of child with marked edema. This is another important viva question. It can be asked. A patient with nephrotic will be there in your case viva, and examiner might ask the DD of child with marked edema. So what can be the causes? Protein losing enteropathy, hepatic failure, heart failure, acute or chronic glomerulonephritis, or protein malnutrition. Kwashiorkor child presents with edema. Okay, and protein losing enteropathies. Protein has been lost. There is defect in protein absorption. Any cause of hepatic failure, chronic or acute, may lead to marked edema. Heart failure, you already know very well, which leads to edema. Chronic glomerulonephritis may lead to edema, and protein malnutrition. So these are the 5 important DD of a child presenting with marked edema. Next is diagnosis other than minimal change disease should be considered. Now, what are the conditions? This is another Viva question. Just go through these. These are important points. These are the only points which are asked in short cases. Quick questions and quick response should be there. Children less than 1 year of age, positive family history of nephrotic syndrome, presence of extrarenal findings like arthritis, rash, anemia, hypertension or pulmonary edema, acute or chronic renal insufficiency, and gross hematuria. So these are in less than 1 year. Usually congenital nephrotic syndrome may present early, but the usual minimal change disease is not seen less than 1 year of age. There should be positive family history of nephrotic, presence of any extrarenal findings or hypertension, chronic renal insufficiency, and gross hematuria. So go through these ones. Now, how to diagnose nephrotic syndrome? Confirmed by urinalysis of the first morning urine sample. Protein creatinine ratio is done from that sample, and serum electrolytes, blood urea, and creatinine, and albumin and cholesterol levels are done to see hypoalbuminemia, hypercholesterolemia. And urinalysis will confirm the protein urea, massive protein urea, nephrotic range protein urea. Protein creatinine ratio of more than 2 is the most reliable indicator of diagnosis of nephrotic. So rule out secondary forms of nephrotic syndrome in children more than 10 years by complement C3 levels, antinuclear antibody, and dsDNA, hepatitis B, C, HIV, and high risk population, kidney biopsy for children more than 12 years who are less likely to have minimal change disease. So kidney biopsy is indicated in children more than 12 years because there are less chances that the patient will have minimal change disease. Any other histological type is suspected in those cases. Now, urinalysis will show 3 plus or 4 plus proteinuria, and microscopic hematuria may be seen in 20% of the patients. Spot urine protein creatinine ratio is more than 2, as we have already read in previous slides. The serum creatinine value is usually normal, but abnormally elevated if there is diminished renal perfusion from contraction of the intravascular volume. So in the later stages, creat may increase. Serum albumin is usually less than 2.5. It leads to hypoalbuminemia and edema. Serum cholesterol and triglycerides are elevated, and serum complement levels are normal. It increases or it decreases in secondary nephrotic syndrome only. So renal biopsy is not routinely performed in patients with minimal change picture. There are other indications of renal biopsy, not in the patient on which you are suspecting minimal change disease. So now we come to the treatment part of nephrotic syndrome. Now, what should be the treatment of initial episode of nephrotic? Tuberculosis must be ruled out prior to starting therapy with corticosteroids. This is very, very, very important. Don't directly jump to corticosteroids in your answer during Viva. If examiner asks how will manage the case of nephrotic, you have to mention this point that tuberculosis to be ruled out. And how we will rule out tuberculosis? You will ask for history, contact history, or any feature suggesting of current pulmonary TB or any lymphadenopathy. You have to order some investigations like ESR, Montex test, or chest X-ray, which collaboration may suggest that the patient is having TB or not. At least you can exclude tuberculosis from these investigations. Now, children with features that suggest MS, minimal change disease, is less likely. What are the features which suggest that minimal change disease is less likely? There is gross hematuria, hypertension, renal insufficiency, hypocomplementemia, or age is less than 1 year or more than 12 years. So these should be considered for renal biopsy before treatment. Now, prednisolone, single daily dose of 60 milligram per meter square per day or 2 mg per kg per day to a maximum of 60 mg daily for 4 to 6 weeks. 6 weeks it's given usually, followed by alternate day prednisolone starting at 40 mg per meter square per day or 1.5 mg per kg every alternate day. This is actually every alternate day for a period ranging from 8 weeks to 5 months with tapering of the dose. So for first 6 weeks usually it's given 6 to 6. For first 6 weeks 2 mg per kg per day, and for next 6 weeks it's 1.5 mg per kg per day. So this is how nephrotic syndrome, first episode of minimal changes is treated. Now, KDIGO glomerulonephritis work group recommends at least 12 weeks of steroid treatment. So, even Indian Academy of Pediatrics have suggested for 12 weeks total, 6 plus 6. 80 to 90% of these children responds to steroid therapy, as we have already mentioned in previous slide. Now, there are a few definitions related to treatment of nephrotic. When it is known as response, that patient has responded to steroids, attainment of remission within the initial 4 weeks of corticosteroid therapy. You have started corticosteroids, and within the initial 4 weeks, if the response is achieved, if complete remission is achieved, then it is known as responsive. Now, remission, urine protein creatinine ratio of less than 0.2 or less than 1 plus protein on urine deficit testing for 3 consecutive days. You have to the features are like decreasing edema, urine output is increasing, and you have to see urine deficit for 3 consecutive days if it's coming less than 1 plus, or if urine protein creatinine ratio, spot protein creatinine ratio is coming less than 0.2 for 3 consecutive days, then you will say that the patient is in now remission. For most children with minimal change disease, responds to daily prednisolone therapy within the first 2 to 3 weeks of treatment. So it takes time. It's not like that you have just started the therapy. Few may respond even earlier, but usually you have to wait for first 2 to 3 weeks for remission. Now, what is relapse? Increase in the first morning urine protein creatinine ratio of more than 0.2. It's not 2 now, it's more than 0.2, or reading of 2 plus and higher for 3 consecutive days on dipstick testing. So this means that now there is relapse. For first time diagnosis, protein creatinine ratio should be more than 2 and dipstick should be plus 3 or plus 4. But now for relapse it should be more than 0.2, 2 plus 4, reading of 2 plus or higher for 3 consecutive days. If the reading is more than 0.2 and dipstick more than 2 plus for even a single day, then it's not considered as relapse. For 3 consecutive days, if it's coming higher side, then this is relapse of nephrotic syndrome. Now, who are termed as frequent relapsers? 2 or more relapses within 6 months after the initial therapy, or 4 relapses in 12-month period. Again, listen and read it carefully. 2 or more relapses within 6 months after the initial therapy, or 4 relapses in 12 months period. Steroid dependent, 2 consecutive as per OPGHI textbook, but otherwise relapse during steroid tapering or within 2 weeks of discontinuation of therapy. Relapse during steroid tapering or within 2 weeks of discontinuation of therapy. If again relapse is occurring, then it is steroid dependent. Okay, now steroids resistance, inability to induce remission within 4 weeks of daily steroid therapy. You started steroid therapy on 1st of November, and even till 30th of November the patient is not responding, then you can term those patients as steroid resistant cases. Okay, so these are very important definitions and can be very easily asked in Viva as well as OSCE. So OSCE, one question they can frame that now in the management part of nephrotic syndrome, just define responsive case, remission, relapse, frequent relapse, steroid dependent, steroid resistance, 1 marks each. So even this can come in OSCE as well as Viva. So go through them properly. Now managing the clinical sequelae of nephrotic syndrome. First, how to manage edema. Edema, sodium restriction less than 1500 milligram daily, water and fluid restriction if the child is hyponatremic, swollen scrotum elevated with pillows to enhance fluid removal by gravity. You have to properly check the scrotum of the patients in nephrotic. There might be severe edema, so you have to manage it properly. Now diuresis by loop diuretics, furosemide orally or intravenously. It should be extremely cautiously exercised. You should not, as I've already mentioned in previous slides, that it should not be the first line of therapy for edema. The patient presents edema, you should not start diuretics directly. You should use it very cautiously when the patient is having distress or severe ascites or massive pleural effusion. Now, aggressive diuresis leads to intravascular volume depletion, increased risk for acute renal failure, intravascular thrombosis. So, you might have seen such clinical cases sometimes. If we aggressively treat the patient with diuresis, it leads to sudden intravascular volume depletion, and sudden patient goes into ARF or some severe intravascular thrombotic episodes like stroke. So, this should be kept in mind. Severe generalized edema with evidence of intravascular volume depletion. That is, edema is also there, intravascular volume is also depleted, patient is hypotensive or tachycardiac, and hemoconcentration is there. So intravenous administration of 25% albumin, 0.5 to 1 gram per kg, and slow infusion followed by furosemide. So both of these things are to be given simultaneously. to increase oncotic pressure and then followed by diuretic. Now, volume overload with hypertension, heart failure, and pulmonary as a complication of parenteral albumin therapy. This can be asked in viva. What are the complications of parenteral albumin? So, to decrease this volume overload and heart failure, we give furosemide followed by albumin. Next is dyslipidemia. How it is to be managed? Dietary fat intake should be decreased less than 30% of calories. Saturated fat should be less than 10%. Dietary cholesterol intake should be less than 300 mg per day. Now, there is no sufficient data to prove the use of HNG coenzyme A reductase inhibitors routinely in children with dyslipidemia. Next, infections, cellulitis, peritonitis, and bacteremia are commonly seen. In SBP, peritoneal fluid should be analyzed. The antibiotic must include pneumococcal and gram-negative bacteria. Third generation cephalosporin is the drug of choice. So this can be asked, what is the drug of choice for spontaneous bacterial peritonitis? Next is thromboembolism. Appropriate imaging studies to confirm presence of clot. Anticoagulation therapy in children. Heparin, low molecular weight heparin, warfarin is effective. Obesity and growth. How to monitor glucocorticoids increases BMI in children who are overweight when steroid therapy is initiated, and these children are likely to remain overweight. Dietary counseling should be done. Steroid sparing strategies can be used to improve growth in children who require prolonged steroids, like in steroid resistant cases. Now, relapse of nephrotic syndrome. I know it's getting very long now, this lecture, but we should finish it as soon as possible. So, relapse of nephrotic syndrome, defined as urine protein creatinine ratio more than 2 or 3 plus protein or diagnostic testing for 3 consecutive days. Common in younger children and triggered by upper respiratory and gastrointestinal infections. Relapses are usually treated similar to initial episodes, except that daily prednisolone courses are shortened. Now, in this case, you should not give prednisolone like in the initial episode we give for 6 weeks, but here we can shorten the course of daily prednisolone. Daily high dose prednisolone given until the child has achieved remission. So for 3 consecutive days, if the urine dipstick is coming less than 2 plus, then we can tag the child as in remission stage and we can stop giving daily dose of prednisolone. The duration of alternative therapy varies on frequency of relapses in an individual child. For steroid resistant cases, failure to achieve remission after 8 weeks of corticosteroid therapy. If you are given steroid for 8 weeks and there is no remission, then it is tagged as steroid resistance. Required further evaluation, including diagnostic kidney biopsy, evaluation of kidney function, and quantitation of urine protein excretion. And it may be caused due to FSGS in 80% cases or other varieties of nephrotic, associated with 50% risk of end-stage kidney disease within 5 years of diagnosis of patient do not achieve a partial or complete remission. If patient is not in remission, that within 5 years of diagnosis, there are high chances of end-stage kidney disease. Now, what are the alternative therapies to corticosteroids in the treatment of nephrotic syndrome? This can also be asked in viva, that alternative therapies for nephrotic syndrome. Who are the candidates for alternative therapy? Steroid dependent patients, frequent relapsers, and steroid resistant. Now, the normal patient, if it is responding to steroid therapy and we have to give only for 6 weeks and 6 weeks during the initial episode, and their relapses are not frequent, the patient is not steroid dependent, no use for alternative therapy and no requirement of alternative therapy. But if these 3 features are there, then we have to think of alternative therapy, as prolonged corticosteroid therapy has many side effects. There can be Cushingoid appearance, hypertension, cataracts, and growth failure in children. So cyclophosphamide is an important component of alternative therapy. Prolonged duration of remission. What are the benefits? Prolonged duration of remission reduces the number of relapses, frequent relapse in steroid dependent nephrotic cases. Side effects: neutropenia, disseminated varicella, hemorrhagic cystitis. You have to remember these side effects. This can be very commonly asked in viva. Alopecia, sterility, increased risk of future malignancy. So neutropenia and hemorrhagic cystitis are commonly asked. 2 mg per kg as a single dose, or for a total duration of 8 to 12 weeks is to be given. And alternate day prednisolone is continued during cyclophosphamide administration. White blood cell should be monitored for neutropenia, and the drug should be withheld if the count falls below 5000. The cumulative threshold above which oligospermia or azoospermia occurs in boys is more than 250 mg per kg. Next is calcineurin inhibitors, cyclosporin and tacrolimus, recommended as initial therapy for steroid resistant nephrotic syndrome. It can be asked which is recommended initial therapy of steroid-resistant cases. So calcium urine inhibitors can be given. Side effects: hypertension, nephrotoxicity, hirsutism, and gingival hyperplasia is seen. What are the doses? Remember these doses: cyclosporin 4 to 5 mg per kg per day, tacrolimus 0.1 to 0.2 mg per kg per day, and duration 12 to 36 months we need to give these drugs. Side effects are nephrotoxic, elevated OTPT, hirsutism, gamma hyperplasia, hypertension, lipidemia, hyperglycemia, neurotoxicity can be seen. Mycophenolate mofetil, maintain remission in children with steroid dependent or frequently relapsing cases. This is the dose, duration is 1 to 3 years, side effect is GI discomfort and leukopenia. Next is levamisole. It's an anti-helminthic agent with immunomodulating effect shown to reduce the risk of relapse in comparison to prednisolone. Next is rituximab, 80% drug-free remission rate at 1 year in patient with steroid-dependent nephrotic cases. And angiotensin converting and the AC inhibitors and ARBs are urgent therapy to reduce proteinuria in steroid-resistant patients can be used. Now, what are the treatment of steroid-resistant nephrotic cases? In short, we can see calcium urine inhibitors can be given, cyclosporin, tacrolimus, cyclophosphamide, IV 6 pulses or oral for 12 weeks. High dose of corticosteroid and cyclophosphamide like methylprednisolone at 20 to 30 pulse therapy, 30 mg per kg IV, pulses on alternate days for 6 doses. This is also known as Mendoza regimen. It can be asked what is Mendoza regimen. So methylprednisolone 30 mg per kg pulse therapy on alternate days for 6 doses with cyclophosphamide, and with prednisolone tapering dose for 18 months, 1.5 mg per kg alternate day for 4 weeks. Then we just taper the dose 1.25 mg per kg for next 4, then 1, then 0.5 to 1.75 for 12 to 18 months. We continue prednisolone on alternate days. Cyclophosphamide is given 2 to 2.5 mg per kg per day for 12 weeks, administered during 3rd to 15 weeks of prednisolone therapy. I hope you have understood this. High dose corticosteroid and cyclophosphamide, how it is to be given. High dose steroids means methylpred, Mendoza regimen 20 to 30 mg per kg IV on alternate day 6 doses, then prednisolone is minimal dose, and then cyclophosphamide with this dose. Immunization, what has to be kept in mind for immunizing the child with nephrotic syndrome? Encapsulated organism, pneumococcal vaccination is to be given, influenza vaccination annually, and even to their household contacts. Defer vaccination with live vaccine until the prednisolone dose is below either 1 mg per kg daily or 2 mg per kg on alternate days. So this is an important point, can be asked in Viva, that what is to be done about live vaccines in patients of nephrotics. So vaccination with live vaccines is to be deferred until the prednisolone dose is below 1 mg per kg daily or 2 mg per kg alternate days. So live virus vaccines are contraindicated in children receiving corticosteroid sparing agents and following close contact with varicella. Immunocompromised child, immunosuppressive agents, varicella zoster, immunoglobulin anyone can be given. So immunize healthy household contacts with live vaccines to minimize the risk of transfer to other infections, like if any other children are there in household contact, live vaccine to minimize the risk of transfer infection to the immunocompromised child, but avoid direct exposure of the child to GI or SP secretions of vaccinated contacts for 36 weeks after vaccination. So how much you should avoid contact after vaccination with a live virus vaccine with live vaccine or 36 weeks after vaccination. Thank you very much. This was a quick recap on nephrotic syndrome. You guys might have read very well thoroughly during theory preparation, but it has been a long time since theory exams were over. So I hope this video will be beneficial to you. Thank you very much. All the best for exams.